Okay, good afternoon, everyone, and welcome to our second virtual hereditary breast and ovarian cancer series. I'm very pleased today to be able to introduce a longtime colleague of ours at Women's College, Dr. Andrea Eisen, who is a medical oncologist at Sunnybrook Health Sciences Center and also is the head of the hereditary cancer program at Sunnybrook. Like I said, she's been instrumental in the delivery of cancer genetic services across the country, including contributing and leading some of the guidelines on genetic testing. And as a medical oncologist, she's also very aware of the latest research in terms of treatment of these hereditary cancers. So I'm thrilled to be able to introduce Dr. Eisen today. Dr. Eisen will be speaking for about 35 or 40 minutes, and then we'll reserve the last few minutes for questions. So if you do have questions, please type them into the Q&A box at the bottom, and we will be using those questions to pose to Dr. Eisen at the end of the talk today. So thank you so much, Dr. Eisen, and I will go on mute and turn off my camera and leave it up to you. So thanks again.
No problem. Thanks very much, Dr. Metcalf. Can everybody hear me okay? Can you hear me? Okay. Thanks very much. My task today is to discuss PARP inhibitors, which are a class of drugs in the treatment and prevention of hereditary breast and ovarian cancer. I'm going to tell you right off the top, I changed it up a little bit. I'm going to really focus, I'm a breast oncologist, so I think I'm going to focus a little bit more on breast than ovary, because some of the newer information is in breast, and as well as some other tumor sites. And there's really not that much happening right now in prevention with PARP inhibitors, so I'm just going to describe that very briefly. This slide shows the spectrum of cancer. I lifted this from a Cancer Care Ontario document, so they refer to it as the cancer journey. And I just put it in to show the range where we go on the far left side from talking about prevention of cancer to then screening and trying to pick them up early, and then the diagnosis of cancer. A big emphasis today is on treatment, and then hopefully recovery and survivorship. But of course, there are some patients where end-of-life care is important. And much of today is going to focus on the treatment, purple box, and a little bit on prevention. I'm showing this slide to talk about the paradigm or how we develop cancer treatments. So typically, new drugs that become available, and I'm going to skip over the whole drug development piece where they're tested in animals and then tested for safety in humans. And I'm going to move everybody ahead to where we know that they're safe and that they have shown to be effective, and that we're testing them out as new treatments against the standard. And usually, we do this first in advanced cancer, in individuals who have metastatic or unresectable cancer. And drugs that have a lot of promise there and are shown to be active often are moved up into early stage cancer. So we use them to see if we can prevent recurrences. And then sometimes after that, we look to see if they're effective as preventive agents. And for example, tamoxifen is one of the oldest treatments we have for breast cancer. It was developed in the 1970s, and the first studies for tamoxifen in advanced cancer really came out in the early 1980s, and it was shown to be quite effective. The previous hormonal strategy for treating women with advanced hormone receptor positive breast cancer was actually to remove the ovaries. So the first studies of tamoxifen showed that it was just equivalent to removing one's ovaries. We started to use it then in the mid to late 80s in early stage breast cancer, and there was a whole series of studies looking at the duration of tamoxifen. Should it be 1 year, 2 years, 5 years, 10 years? And then in those studies, tamoxifen was shown to reduce the risk of a woman with breast cancer having a recurrence of the disease, but also it was noted that women who took it had a lower incidence of getting a new cancer in the opposite breast. And that led to several other trials looking at tamoxifen as a preventive agent. And those came out in the in the late 90s, early 2000s. What are the PARP inhibitors? PARP is an enzyme that is important for the repair of DNA damage, and particularly single-strand DNA damage by a mechanism called base excision repair. And if PARP is blocked, the cells can then develop further DNA damage, typically double-strand damage. And in normal cells, other mechanisms are able to repair double-strand damage. But in cancer cells that have BRCA1 or 2 mutations, these other mechanisms are faulty. And that allows the cells to accumulate ongoing damage and to die. So it's a mechanism or a drug target that exploits the sensitivity of BRCA1 and 2 mutations in cancer cells. And this is a schematic which really simplifies that, and that's why I like it, from one of the PARP inhibitors called Rubraca, which is the brand name. And it just has 3 panels. Basically, cancer cells with damaged DNA are shown on the left. The PARP enzyme would normally be repair any damage to the DNA. So you see that little nick in the DNA here. And the PARP is indicated as a screwdriver that might repair that. But the PARP inhibitor blocks, the drug blocks this screwdriver, the repair mechanism, from binding and fixing this damage, and the cells accumulate further DNA damage and die. So there are other mechanisms and other ways that PARP inhibitors are effective treatments, but this is the primary one. I think I'm going to skip over this today. I think it'll take a little bit too much time, but it's a kind of a cute cartoon that says what I just said in nicer pictures. There are several PARP inhibitors that are clinically available and have been tested, and this is really a list of the most of the ones that are in use now. I don't think it's not in the scope of today's talk to go into the pros and cons of each one and how they're a little bit different, but I've included them here as a list so you know what we're going to be talking about. And then before we go into the nitty-gritty of how they're used in different cancers, and in particular hereditary cancers, I wanted to just take a moment to talk about the side effects. These are oral medications, and we like, as oncologists and as providers, and I think as patients too, to be able to use oral drugs, because then you don't have to go to the chemo suite for treatments. It's more simple, but I think there's sometimes a misconception that an oral drug means it has less side effects. And the PARP inhibitors are generally well tolerated, but they do have side effects. They commonly cause low blood counts, particularly anemia. They can cause fatigue. There's a typical kind of nausea that people get when they start these at the beginning, but generally that passes quickly. And then rarely there's a potential concern about pre-leukemia called myelodysplastic syndrome, or even acute leukemia. And that's thankfully a very rare side effect, but it's a reminder that these are not benign treatments. Okay, so how do we identify potential candidates and by that I mean individuals or people who might benefit from PARP inhibitors? So here's some of the considerations. Most of the studies have looked specifically at BRCA1 and BRCA2 mutation carriers, because we know that BRCA1 and BRCA2 proteins are important for that double-strand DNA repair. And when it's defective, that's when we run it. That exploits the mechanism of PARP inhibitors. But there are certainly other mutations that are involved in DNA repair, other genes that may be involved in DNA repair that could be important targets for the PARP inhibitors. The other big question is whether we restrict or whether we include only individuals who have inherited mutations in these genes, say BRCA1 and 2, versus individuals who may have tumors that have acquired mutations in these genes. And it's actually different categories of patients have been included in different trials for different diseases. So in the breast cancer studies of PARP inhibitors, we've really just focused on this germline group, women and men who have inherited mutations in BRCA1 and 2. Whereas in ovarian cancer, both inherited and somatic or tumor mutation patients have been included. In pancreas cancer, which I'll come to a little bit later, Again, it's mostly germline mutation carriers that have been included, but in prostate cancer, the trials have included mostly tumor mutations and many different genes. This makes me, I'm going to come to this point again later, but it's a practicality or an implementation point that we have to be certain that one can find out if they are a mutation carrier and a potential candidate for this gene. And the model that's available now for ovarian cancer has been a good lesson for us, but we certainly don't have the same access and widespread testing for example, all new breast cancer patients or all new pancreas or prostate patients. And this is something that we need to address. And then finally, because I don't have a lot of time, I've simplified some of the discussion, and I want to just remind us that the criteria for using these drugs right now are based on how people were selected in the clinical trials. So they're usually quite restrictive criteria. You have to have a certain amount of prior treatment and not too much treatment, not too little treatment, certain subtypes of disease. And so if I don't get into all of those details today, I have listed the publications, and I'd be glad to address some of that in the questions. Okay, so the first one I'm going to talk about is PARP inhibitors in BRCA1 and 2 ovarian cancer. And I'm going to spend the least amount of time on this because this is the area where there are multiple clinical trials with quite robust evidence. And this is the indication that is already publicly funded, for example, in Ontario. And there have been multiple clinical practice guidelines and evidence summaries written for this. So for example, this is a snapshot of the recent guideline published by the American Society of Clinical Oncology, which did a very extensive review of the data. They looked at all the trials that were published between 2011 and 2020 for women with epithelial ovarian cancer, and generally focused on the 4 PARP inhibitors that are listed there. They did not include in this guideline all of the early stage studies, but really looked only at randomized trials where treatment with a PARP inhibitor was compared to another standard, and they identified 17 trials. These are the questions that the guideline authors addressed. Should people have a chance to get a PARP inhibitor more than once? Which patients benefit the most? Should you use PARP inhibitors alone? Are there settings where you should combine it with chemotherapy or other targets? And how do you manage the toxicity? And here's the bottom line summary. In oncology, we refer to first line treatment as when someone has advanced disease, the first attempt at therapy. So the first line of treatment that you receive. That's pretty intuitive. And so recently it's been shown that for women who have advanced ovarian cancer, of the subtypes listed here, high-grade serous or endometrioid, and for the drug olaparib who have germline or somatic BRCA1 or 2 mutations, if you get a good response to your first-line chemotherapy, then there's a big benefit from taking olaparib. And so, for example, I've listed there the SOLO-1 study, which compared olaparib to placebo, and there was a 70% improvement in preventing recurrence, preventing progression of the disease using olaparib instead of the placebo. The second line is after women have had their first treatment in the event of a relapse. We then would, if a certain amount of time has elapsed, we would consider giving further chemotherapy, again, a platinum-based chemotherapy. And in this case, if women have had no prior PARP inhibitor, so their first diagnosis happened before the first line PARP inhibitors were available, in women who have a germline or somatic BRCA1 or 2 mutation, there are 3 PARP inhibitors that have shown to be effective. And for example, in the trial that's listed at the bottom there, SOLO-2, women who got the PARP inhibitor olaparib instead of the placebo had a much longer survival without progression of their cancer, 19 versus about 5.5 months. And they also lived longer, on average 52 months versus 39 months. And that's, we seldom see improvements in outcome as great as that. And that's what led to the availability of this drug in the second line setting. Okay. And those are really the main 2 points about PARP inhibitors in BRCA ovarian cancer. The drug niraparib has been tested in all women, regardless of germline or somatic BRCA1 or 2 status, who have ovarian cancer that's high grade or serous and shown to be effective. Okay, so what about breast cancer? So as I showed before, we typically start these trials in advanced cancer. And in breast cancer, for BRCA1 and 2 mutation carriers and the use of PARP inhibitors, we really have focused on germline mutations, so not mutations that may have happened in the tumors. And there's been 3 major trials in this setting. The first one is called Olympiad, the second is Embraca, and the third is Brocade 3. There's been other smaller studies, but I'm going to focus on these 3. Olympiad used the drug olaparib, Embraca used the drug talazoparib, and Brocade 3 used the drug veliparib in combination with chemotherapy. And in all of these studies, the comparator was standard chemotherapy. In the Brocade 3 trial, they used a placebo plus chemotherapy in order to maintain the blinding of the study. So here's a summary of the outcomes. On the far left here, I've shown what the description is, and then here are the 3 trials and the publications where you can find them. So the Olympiad trial was published 3 years ago. It included about 300 women who had germline BRCA1 and 2 mutations. Everybody had prior chemotherapy, and if they had prior endocrine treatment, if they had hormone receptor positive disease, they were allowed to have and had to have had at least 1 prior endocrine therapy. And the outcome here is shown in this column. The progression-free survival, so that's the amount of time until the cancer started to progress again, in the group that got olaparib was 7 months versus 4.2 months in the group that got the placebo. There was no difference in the survival. So we cannot say that giving olaparib in this setting will definitely make you live longer. The treatment was better in women who had triple negative breast cancer and had fewer prior treatments before entering the study. And in fact, when you compared the olaparib to the chemotherapy groups, there was less side effects, less toxicity in the olaparib group. The second study was Embraca. Then there have been, the original publication was also in 2018, but it was updated more recently. And this looked at the drug talazoparib. It was a similar study design. Patients were randomized to get either this drug or a placebo. They were allowed to have had prior chemotherapy, and it wasn't necessary, but they could have had prior endocrine therapy if they were hormone receptor positive. Again, this study showed a benefit in time to progression, 8.6 months versus 5.6 months, but there was, again, no difference in survival. They did a more detailed analysis of the quality of life of patients on this study, and they found that the PARP inhibitor patients had a higher quality of life when they did formal measures of that than the patients who received chemotherapy. There was more anemia in the PARP inhibitor patients. And the last study, and these 2 drugs, by the way, are commercially available. The last study was a study called Brocade 3, which was published last year. It used a drug called veliparib, which is not yet commercially available. And it was a larger study. It allowed patients to have prior chemo. Again, these were germline BRCA1 and 2 carriers. And it was veliparib plus chemo or placebo plus chemo. And it showed also a modest benefit in the time until the patient's cancer got worse, but no difference in survival. And really, the PARP inhibitor did not add a lot to side effects or take away from the quality of life in this trial. So that's a summary of the trials in advanced breast cancer related to BRCA1 and 2 mutations. Unfortunately, the impact and the benefit in breast cancer doesn't seem to be of the same magnitude that we see in ovarian cancer. But we have a lot of prior lines of therapy in breast cancer, and there's more evidence that these drugs work better if you give them earlier And also they work better in women who have triple negative disease. So that was promising enough for a trial to start in the adjuvant setting, or an early stage breast cancer, to try to prevent recurrence. And this is called the Olympia Trial. And it was a study of 1 year of olaparib compared to a placebo. It has adjuvant therapy after chemotherapy and surgery. And to get into the study, you had to have pretty high risk disease. If you had your chemotherapy before surgery and had triple negative disease, at the time of surgery, you had to have pretty significant disease left over that didn't get completely killed by the chemotherapy. And if you had estrogen receptor positive breast cancer, you had to have very significant disease, at least 4 positive lymph nodes and a lot of residual. And we participated in this study in Canada. It was run by the Canadian Clinical Trials Group. And we call all the breast cancer trials by MA. So this was called MA36. And this is just the full title of the study. And this is a schematic to show you how it worked. You could be screened for BRCA mutations prior to going on the study. That was considered part of it. And you could either have your chemotherapy up front or your surgery up front. And depending on what you had after your surgery, whether you had some residual disease, so that means there was not a complete response, you would go on to get radiation and then be randomized to the treatment, either the PARP inhibitor or a placebo. It was a blinded study. And this was a massive effort because, there's just not a lot of known BRCA carriers with breast cancer who met the criteria. Over 300 centers worldwide participated in this study. This shows you, though, that once centers decided to participate, they were able to put patients on the study pretty quickly. And the final patients went on in March of 2019. So there are no longer any patients who are receiving the treatment. The top box here, I think this is pretty interesting. This red line with the squares shows you how many patients had to be screened to have testing for BRCA in order to find enough carriers to do the study. The total sample size was about 1,600. And so it was about 10 to 1, about 10 times as many patients had to be tested as were found to be eligible. And actually, this is kind of timely and pretty exciting because we just had a meeting for this study this week, and there's been a press release that showed that the early results from Olympia are positive, that it does look like there's a benefit for PARP inhibitors in women with early stage BRCA-related breast cancer. This is IDMC, stands for Independent Data Monitoring Committee, have recommended that the data be unblinded and the analysis go ahead. And it's anticipated that early results might be presented later on in the spring. So that's pretty exciting, but it also opens up some challenges for how to make sure we identify women who might participate. So I've shown you ovarian cancer, I've shown you advanced breast cancer and early breast cancer, including some hot off the press results. I want to also talk a bit about PARP inhibitors in pancreatic cancer, because that's also quite new. This study was published, I felt like it was more recently, but it's 2019, a study called the Polo trial. And this study enrolled about 150 patients who had advanced pancreatic cancer and who have mutations in BRCA1 or 2. And in order to get into the study, you had to be on chemotherapy and have at least stable disease after 16 weeks of chemo. And a lot of patients don't meet that bar. So you had to pick people who were generally doing well after the first 4 months. And they were randomized after the chemo to go on to olaparib, the PARP inhibitor, or a placebo. And here's the results that were published, again, in 2019. The progression-free survival was greater. So it took longer for patients who got olaparib for their cancer to get worse than patients who got placebo. This looks like a small benefit, but for pancreatic cancer, that's actually quite important. There was no difference observed at this early analysis in survival. So the median survival of the patients was about 1.5 years. And there was no difference in the quality of life, the patients who took olaparib or placebo. So it's important to know that this benefit didn't come at the cost of a lot of toxicity. I've left prostate cancer because I find this is the most difficult to explain and summarize. It's obviously a huge group of patients, men with advanced prostate cancer who are no longer responding to hormonal maneuvers. PARP inhibitors have been studied in men who have germline mutations in BRCA1 or 2, but other genes as well, or tumor mutations. And those tumor mutations can be detected by a wide range of methods, by actually looking at a piece of the tumor or by looking at circulating tumor cells in the blood, etc. And as I mentioned before, BRCA1 and 2, but other genes that are involved in repair of DNA damage, HRR. And these include ATM, CHEK2, and PALB2. And one of the most important, there have been several smaller studies that showed activity of the PARP inhibitors in this group, but this PROfound trial that was published last year is really the first one that was a randomized study compared to the standard of care in this patient subgroup. And these were patients, about 400 patients out of over 4,000 who were screened, who were randomized to get either olaparib, the PARP inhibitor, or the standard of care. And they tested for they did testing on the tumor, so not blood testing for inherited mutations, but tumor testing. And they tested for these 15 genes, and not all of these have previously known to be involved in the PARP inhibitor pathway. So that's one of the criticisms of the study. But they also they looked at the results for this group here, BRCA1 and 2, or ATM, and called that cohort A, compared to everybody else. Okay, so the results that I'm describing here are for the cohort A, the ones that are more known to have a potential benefit from PARP inhibitors. And in this study, men who received the olaparib compared to those who got the standard of care had an improved survival without progression of their cancer, again of about 3 or 4 months, 7.4 versus 3.6 months. And there seems to be a trend towards an improvement in survival. So the original publication said it was about 3 months, 18.5 months versus 15.5 months. And the more recent publication widened that a little bit. It's 19 versus a little under 15. Interestingly, they did note that there was more toxicity in the group that got olaparib, especially anemia and nausea. But when they did formal measures of quality of life, it seemed to be better in the group that got olaparib than that got the standard other treatment. There's emerging evidence in prostate cancer for other PARP inhibitors, including these ones that are listed here, rucaparib, niraparib, and talazoparib. And there's a lot of analyses ongoing right now of outcomes with different tumor mutations picked up by different techniques. So very interesting and important work, and particularly if we see better survival, I think we could anticipate seeing that we will try to make this drug available clinically. So how do we access PARP inhibitors in Ontario? And I wanted to highlight a difference between drug approval versus drug funding. Approval is through Health Canada, and that is the mechanism, the regulatory process to ensure that drugs are safe and have been tested properly. I think we're all becoming experts with the concept of approval from Health Canada related to COVID vaccines, and it's a similar process for drugs. Okay, it's a rigorous review. Funding is a different story. That's more of a national review process, again, but healthcare in Canada is a provincial responsibility, and so decisions about implementing drugs are made by province. So the only approved and funded indications for PARP inhibitors right now are for BRCA1 and 2 related ovarian cancer. Other drugs have been approved by Health Canada but are not funded, and that may not seem an important distinction, but these are very expensive drugs, in excess of $7,000 per month of treatment. And so for most individuals, if it's not publicly funded, it's a major access problem. I'm just aware of the time, so I'll go over these a little bit more quickly, but I really wanted to just make the point here. This is a schematic of how cancer drugs get funded in Ontario. And I just wanted to make the point that it's a bit complicated. First, there comes a regulatory approval by Health Canada, and then a national review by what's called PCODR, the Pan-Canadian Oncology Drug Review, and every province except Quebec. Well, I think actually Quebec does participate in this now. This body reviews all the clinical evidence and also looks at the cost effectiveness of drugs and makes recommendations about whether they should be funded or not. And then this body, the Pan-Canadian Pharmaceutical Alliance, negotiates the price with the manufacturer of the drug, and then it moves on to the provincial level where decisions are made about implementing and funding the drugs. Okay, this is just to show you that at the PCODR, the national review process, this is how it works. There's pre-submission planning, there's an opportunity for clinician groups to provide input. There's a preliminary report where you can give more input, and then final recommendations are made. So really meant to not go into this in detail, but just to highlight the complexity. So on one hand, we have difficulty in accessing the drug because they're expensive and we haven't made it through all those review processes yet. On the other hand, we also have to be sure that we can find all the patients that might benefit. So currently, ovary cancer is really the only one where we have a really broad approach. Every woman who's newly diagnosed with ovarian cancer has testing for BRCA1 and 2 mutations, generally on the tumor first and then for inherited mutations. But for other cancers, we still employ relatively restrictive criteria for selecting who might be a candidate. And I think this is a legacy of the time when genetic testing was pretty expensive. And so it was a scarce resource that we had to ration carefully. The price of genetic testing has really come down, and also implementing criteria is resource intensive. You have to collect family histories from everybody. You have to confirm pathology in some cases. Every patient file gets touched usually by a genetic counselor or a clinician. So really it's a delicate balance between making sure we can broaden the criteria to identify patients who might benefit and being sensitive to overwhelming the system. For breast cancer, there are some international groups that have advocated that all newly diagnosed patients should be offered genetic testing so that they don't miss out on opportunities like PARP inhibitors or the opportunity to make more informed surgical choices. That, you know, and clearly if we're going to get to a point where the Olympia study, the olaparib is funded for early stage breast patients, we have to be able to identify them. And that's what's happened in ovarian cancer. And so we need to consider whether our criteria should be modified or more inclusive. And obviously there are funding implications for that. Okay, here's my one slide on the prevention of breast cancer with PARP inhibitors. Really, it's investigational at this point. There are potentially some serious toxicities from PARP inhibitors, and they're very expensive. And we do have other ways to reduce the incidence or the risk of breast cancer in women who have hereditary susceptibility, such as endocrine options or preventive surgery. And so I think we'll need a bit more information before this really moves ahead in a big way. In particular, the trials like Olympia, where early stage patients were offered the treatment. I mean, you can imagine that many of those women may have had bilateral mastectomy. And so that we don't have the same opportunity as we did with the tamoxifen studies to look at the risk of cancer in the other breast. But not all women in that trial did have bilateral mastectomy. So we might look for a signal there to see if taking the PARP inhibitor for a year reduces the risk of getting a new cancer as well on the other side. So to summarize, PARP inhibitors are established in the treatment of BRCA-related ovarian cancer, and they have led to significantly improved outcomes and are widely used now. For other advanced BRCA and other DNA repair gene-related cancers, there's more evidence to support PARP inhibitors in advanced and early breast cancer and pancreas cancer and prostate cancer. We probably need more testing to identify appropriate candidates and a bit of a paradigm shift in how we approach this in Ontario so that we make sure we don't miss anyone who might benefit. That's the end of what I had prepared for today. I'm hoping I left enough time for some questions.
Thank you so much, Dr. Eisen. That was excellent. And it's nice to hear some of the latest data on PARP inhibitors and the use of PARP inhibitors in BRCA1 and 2 mutation carriers. So the next few minutes we'll spend just answering some of the questions or posing these questions to you, Dr. Eisen, that have been raised by the group today. I think there's some interesting questions and maybe some food for thought on how we might think about some questions going forward anyways. There's a few questions on the length of time that women, especially with ovarian cancer, are being put on PARP inhibitors. And I see from some of the chat, women are suggesting the 2-year. And I know you're not treating that many ovarian cancer patients, but can you talk to us a little bit about why these women are put on PARP inhibitors for a maximum of 2 years?
Well, the short answer is that's the trial design. And it's unlikely, given the cost of the drugs, that we can just use them endlessly until disease progression. Using that interval, it's usually a trade-off between potential toxicity and benefit. And using that interval has led to important improvements in outcome. So it's possible that longer intervals or even shorter intervals will be addressed later, but for now, that's the evidence supports that duration of treatment.
Right. So it will be similar to what we saw with the earlier tamoxifen trials.
Yes.
Yes. Okay. Great.
And similarly, in HER2-positive breast cancer, for example, not necessarily hereditary, but the use of the drug trastuzumab or Herceptin, the initial studies used 1 year duration, and there have been other studies that looked at 2 years versus 1 year, and 2 years wasn't better. And there have been studies that have tried to look at a shorter duration, 6 months, for example, for women with lower risk disease. And it wasn't clear that you didn't give something up by using a shorter duration. So we're stuck with 1 year.
Right. But it really speaks to the importance of research and doing these large trials and thinking about different designs. And for women getting involved in some of these trials, these are the questions that are being answered, not just the effectiveness.
Correct. Yeah.
Great. Okay, thank you. And I'm going to introduce Dr. Joanne Katsopoulos as well, who is the scientist in our team, and she's going to help me with some of the questions as we're going through. So I encourage you to keep posting your questions and reminding you that we will also be posting these videos online on our website. So if some of your family members wanted to watch them, they will be available for watching at a later time. So Joanne, did you want to go with the next question?
Hi, everyone. Sorry, I was having technical difficulties as usual lately. Thank you, Dr. Eisen. That was really great. So the question Dr. Metcalf just asked was a very common theme here. So something that you kind of touched upon at the end of your talk was women, or the idea of using PARP inhibitors for prevention. So a few women that were on this talk have asked about their treatment of their ovarian cancer with PARP inhibitors. And so now would this potentially prevent their breast cancers from happening? Yeah. So women who might still have 2 intact breasts, who have not had a mastectomy, or who have not had breast cancer yet.
Yeah. That's not a well-reported outcome yet in those ovarian cancer studies. Obviously, those data are being collected. I think in the time that women have been followed so far, the risk of recurrence of ovarian cancer is really the dominant risk for health, as opposed to the significant but much smaller incremental risk every year of breast cancer. So it is something important to look at, but I'm not aware of the outcome of those data.
So I guess, as an add to that, that's why it's important for women to continue to have their breast screening following their diagnosis of ovarian cancer, would you say?
Yeah, that's a difficult point, Joanne, because we often tell women if they have advanced ovarian cancer and they're just finished their chemo or they're just starting a PARP inhibitor, that we recommend waiting a little while before starting breast screening, just because the threat to their health for at least the first year or two is so much greater from the ovarian cancer recurrence.
Okay, thank you. It's again, a very complicated, some of these questions are very complicated and really dependent on prior histories of other disease.
Yeah.
Okay, Dr. Metcalf.
Okay, I'm going to open it up to a question I think that's both near and dear to both of our hearts, Andrea, and it's about the access to genetic testing. And we have a talk later on during this virtual series talking about access to genetic testing, but the question is about the guidelines in other provinces. So many of us are here in Ontario, although I do think there are some participants across the country. So can you tell us a little bit about the guidelines across the country, and is there any province in which genetic testing is available to all women with breast cancer, especially at the time of diagnosis?
Yeah, so I mean, we actually are in a pretty good position in Ontario because we have a well-established series of cancer genetics clinics with the mandate to see individuals with family histories or personal diagnoses that were incorporated and started as part of the high-risk screening program. So there are over 25 sites in the province where women can go for genetic counseling. And I'm mentioning that may seem like a low bar, but compared to other provinces, we're quite lucky that way. I'm not aware of any province that has, open testing for any woman with breast cancer. I think in Ontario, I'm biased. I think we have very thoughtful criteria, and these are actually being reviewed right now to try and broaden them a little bit and to improve access. But I want people to be reassured that, we certainly are aware of the need to make sure that no one's missed if there's a potentially helpful therapy. And often when a drug comes forward, let's say Olympia comes forward, olaparib comes forward for early stage breast cancer, the funding body considers that the test has to be done too. It's not just the drug in isolation. And that's what happened with ovarian cancer. So as many people know, there was really an under-referral of women with ovarian cancer for genetic testing for a long time for lots of reasons. Complex illness, lots going on at the beginning when you were first diagnosed. But now that the drug olaparib or Lynparza is used broadly, many more women almost all women are really being referred for testing. So we can hope that when the drug is available and funded and we can use it, that the same thing will happen. But in the meantime, we have to keep our guard up and advocate for more open testing. Because as you know, not like Kelly, it's not just about the medication, but also for surgical decisions too.
Right. And so
there's a long answer to say, I think we're in pretty good shape in Ontario, and but I don't think any province just allows anyone to be tested.
Great. Thank you so much. Joanne, did you want the next question?
Sure. So there's a little bit of, I guess, a lot of questions regarding your BRCA1 versus BRCA2 status or hormone receptor status of your breast cancer for the PARP inhibitors. I mean, given that the samples were about 300 to 400 women in the trials, was there any differentiation or better effect in carriers of either mutation, or were they lumped together?
It's interesting. For prostate cancer, BRCA2 mutation carriers seem to benefit a little bit more, but those studies were pretty small. The PARP inhibitors in breast cancer seem to work a bit better in triple negative disease. And so we see that more in BRCA1 carriers than BRCA2. So in that respect, there's a little bit of a difference. And for ovarian cancer, actually, I think I went over it pretty quickly, but one of the PARP inhibitors has approval, at least in the United States, to be used in all high-grade serous or endometrioid ovarian cancer, even if you don't have a mutation. So there isn't one answer across the different diseases.
Okay, great. Thank you.
Okay, and I think we'll ask the last question here, and I did just have one. Recruitment of patients into PARP inhibitor trials. Are there any still ongoing in Ontario or across Canada that patients can enroll in if they meet the criteria? Or is there access for breast patients outside of a trial?
Oh, it's can I answer the second part first?
Sure.
We have a difficult situation in Canada right now where there is really very, very limited access to PARP inhibitors on a compassionate basis. In fact, there's no access on a compassionate basis, and it has a lot to do with the change in the rules for funding. Both PARP inhibitors that have been approved by Health Canada, olaparib and talazoparib, the manufacturers have elected not to go forward for funding, okay, at this time. And when they don't go forward for funding and they don't anticipate funding, then they don't have a compassionate program. So it's a sad thing that there are some women who participated in the studies and maybe have disease relapse and can't have access to the drug right now. And we're hoping that that will change and things might change, but we have very limited access for breast cancer right now. For ovarian cancer, there's good access through publicly funded programs. And for other cancers, yes, there are always ongoing, a lot of the new trials are looking at PARP inhibitors in combination with other agents. So it's always worth asking your oncologist. And there are websites and directories you can consult for ongoing studies.
Great, thank you.
So I think we'll take the last minute to thank Dr. Eisen for a very important and really clinically relevant seminar. I think a lot of us are still learning about PARP inhibitors and their role in helping treat BRCA-associated cancer and potentially other hereditary cancers. So thank you so much for your time. We appreciate it. We hope we've done the best we can at answering all the questions. There were a lot, but.
Great.
I was going to say it's nice to see everybody. Sadly, I can't really see anybody, but thank you for including me.
Thank you for your time. And so we will post this video on our website, on the Women's College website. We don't know exactly where it's going to be posted, but I think you'll be able to find it in the Hereditary Cancer unit, definitely, and on the Peter Gilligan portion of the Women's College website. And for those of you who are interested, our next monthly seminar has been posted here, and it's also found on the Eventbrite website at the bottom of this slide. And so Dr. Ellen Warner will be talking about screening for hereditary breast cancer on Friday, March 19th. So thank you everybody for your time. We hope you enjoyed the seminar.
And we will be sending out an evaluation form for you to fill out. So please let us know your thoughts, how we can improve, what you liked about this as well. As we go forward, we're committed to bringing you all the latest research, and we'll be continuing these webinars throughout the year and hopefully into the future years as well. So thank you so much for your participation, and we look forward to seeing you next month. Thank you.
Have a good weekend, everybody.
Bye.
Thanks very much.
Bye.
Bye.
Thank you.
Bye.